I want to introduce our next speakers. They'll be talking about the intersection of perinatal mental health and substance use. And it is with great pleasure that I get to introduce our next speaker, Cara English. She is the Chief Executive Officer of Cummings Graduate Institute for Behavioral Health Studies and founders of Tara's Tribe, a maternal health advocacy organization in Phoenix. Cara has extensive experience working with women and families with mental health challenges in both acute and community settings. I only have time to mention a few of the positions she has held in the perinatal field, but they include having served as Vice President of Postpartum Support International. She's a member of the Maternal Mortality Review Program and the Maternal Health Task Force for the Arizona Department of Health Services, and a consultant to the Fourth Trimester Arizona nonprofit organization. Her co-presenter today is Valerie Kading, CEO of Sierra Tucson, where she provides the strategic vision to ensure the facility's patients and their families receive innovative, compassionate, and care. Valerie has a special interest in women's mental health, including perinatal mood disorders, maternal well-being, and postpartum depression. For both of our speakers today, I want to encourage you to go into Whova and check out their biographies, which are extremely impressive and much longer than what I presented today in their introduction. So I'm going to turn it over to you, Cara.
Thanks, Jeanette. I appreciate it. I'm going to share my screen now. All right. Are you able to see my slides?
Looks great.
Okay, great. So let me go back actually a couple ones. I appreciate the invitation to speak today and was happy to be part of the planning committee with this wonderful group of very passionate people here in Arizona. So with Dr. Kading today, we are going to hopefully share a lot of helpful information and answer some of your questions as well about the intersection of perinatal mental health and substance use. So first and foremost, we wanted to thank previous speakers. Dr. Keller-Halls mentioned a lot about the adverse childhood experiences study that the CDC did in partnership with Kaiser Permanente. The study was published in 1998, but most medical providers and behavioral health providers that I speak to today on a regular basis, either through the university education that I provide or through community education presentations such as this, are still not aware of the data and the impact of that data on how we assess and work with individuals in a health and wellness service within our communities. So it's important to just level set and make sure that everybody really has a good understanding of how that data impacts women and birthing people who are more vulnerable during the pregnancy and first year after birth than at any other time in their lives. So today we'll be going over mental health and substance use and dependence and trauma and the way that those three interact with one another to impact wellness for a mother, her child, and the entire family. So as Dr. Keller-Halls mentioned, trauma exposure is scientifically connected with our health outcomes, and there is a dose-response relationship, meaning the more categories of adverse childhood experiences that an individual has in their life prior to when they turn 18, the more impact, the negative impact has the potential to drive their health outcomes in the direction that we don't want. And so we want to make sure that we have a good understanding of that, as well as the impact of positive experiences, both in childhood and in adulthood, and how those can serve as protective factors that are helpful to ward against the risk factors that we may have had due to those adverse childhood experiences. They also ward against trauma in adulthood because there's developmental trauma that we experience as a child. There's also event trauma that we experience as adults. And so we want to make sure that we have a good understanding of how the developmental trauma and the event trauma are impacting the person now. And we want to understand how we can increase the protective factors and reduce the risk factors in their life to help improve outcomes. So I like to share the pair of ACEs, which is the ongoing research into how adverse childhood experiences, and the other ACE, which is adverse community environments, impact our health on a day-to-day basis, and certainly our health over time, and not just our health. There was a recent study that found that untreated perinatal mental health challenges account for about 72% of the child's health difficulties and challenges as they move through school and life. And so it's important for us to understand that anything we can do to reduce our risks and improve our protective factors is going to help in the long run our families as they grow. So what we can see here in this visual is that anything above the ground line, the tree, this big beautiful tree that's growing, we see the tree growing, we see all of these leaves. And just in kind, we can see if a person is experiencing homelessness. We know if they're experiencing incarceration, divorce, if they're experiencing physical and emotional neglect, mental illness, substance abuse, domestic violence, etc. We can see those things because they're sort of above the ground mark. Oftentimes people don't talk about all of those factors, but they are things that we can usually part of an assessment or a wellness check. Not always, but we hope. Certainly it's best practice. Anything though that is below the ground is adverse community environments that are not usually accounted for when it comes to looking at a person and their whole health picture. And so these are some of the things that are considered social determinants of health, or SDOH. And these are things such as poverty, discrimination, community disruption, a lack of opportunity, economic mobility and social capital, poor housing quality, as well as poor housing affordability, and violence in the community. And so the pair of ACEs is really important as we consider how these factors impact our health and wellness and our capability of parenting. So for any of those in the audience who are parents and have been parents, we all know how difficult the job is. And so when we have the developmental trauma, as well as the ongoing trauma of being in an adverse community environment, we know that our health is not going to be optimal. So all we can do to reduce those risks and improve the protective factors will help everyone. So let's talk a little bit about how trauma developmentally, as well as environmental trauma and event trauma, such as a traumatic birth experience, can impact perinatal mental health. So there are many factors that have an impact on the maternal health as well as paternal health, and we're not excluding partners and fathers in this discussion today. So I want to make sure we point to that. But we really have to be thinking across the spectrum of what those factors are. So just to kind of set the foundation, the scope of the problem, before COVID-19, we knew from World Health Organization data that women as a gender or as a population are 1.5 to 2.5 times more likely to experience poor mental health in their lives. And that is relative to men in the same age range. And so what we want to know, about all of the women that we are working with, certainly the individuals who are becoming pregnant, is that, that rate of depression or that risk of depression is already higher just due to being a woman in the world. Suicide also accounted for about 20% of postpartum deaths and was considered the second leading cause of death in postpartum women, according to Postpartum Support International. And Dr. Catherine Weisner, who's a national thought leader in this area and certainly a researcher in this area. So we want to know how high the risk is for women during the time that they are pregnant and birthing people while they're pregnant, as well as during the full year after birth. We also want to know that recognition and treatment rates are lower for pregnant and postpartum people than in the general population. And so for whatever reason, and some of those reasons were mentioned earlier, especially for individuals with substance abuse, we're afraid of showing up as our full selves. in a room with a health provider, especially if we have low trust in that individual, and especially if we are worried that anything that we say, including we are struggling with mental health, we are struggling with substance dependency, we're struggling with, a poor social support system, or we just don't have the coping skills we wish we had. All of these are factors in whether or not people feel comfortable self-reporting these challenges with a healthcare provider, and therefore whether or not they're going to get help. So as individuals, when we are working with birthing people and their families, we need to make sure to be proactive in asking and assessing and creating the report in a safe and trauma-informed environment. Antenatal and postpartum depression also increase the risk for multiple adverse outcomes for the infant and child as they grow through life, and for the family in general. So we want to make sure that we know that this is a very vulnerable time. We want to know that the risk is higher for individuals who identify as a female. We want to know that the outcomes for their own health, as well as the health for their partner and their entire family, are impacted when we don't assess and we don't treat adequately. So let's talk a little bit about how COVID-19 has impacted perinatal mental health. Prior to the COVID-19 pandemic, we were hearing from mothers and birthing individuals that anxiety was high. It was already high. So you're looking at a 29% of anxiety within the population of birthing individuals. Depression was at 15%, and those are self-reported statistics. So for a population, we were already not doing super great. And then COVID hit. And since the COVID pandemic, and certainly this was a 2020 statistic, and I have not seen additional research in 2022 to measure what that rate is now since 2022, but I would imagine it's still very high. Anxiety was being self-reported by 72% of mothers who were surveyed, and 40% of those who were surveyed, almost 41% of those who were surveyed, were self-reporting depression. And that's due to a lot of factors that we're all aware of. COVID certainly drove us into more isolation, and many people had more difficulty accessing healthcare, and certainly mental health care. The need and the demand for mental health care services went far above what most communities were able to provide. And that certainly is true for here in Arizona. We're in a health provider shortage area across most of the state of Arizona. So there just aren't enough professionals to meet the needs. So when we're in that situation, we need to know as providers that there are some things that we can do, one of which was mentioned early on in today's agenda, which was the postpartum support international training that was provided to over 200 providers across Arizona in 14 out of 15 of the counties. Certainly increase the workforce that we have to meet the needs of perinatal mental health services. But it's, again, just something that we need to keep in mind, that when we're working with birthing people and their families, we're most likely to see individuals who have some concerns or, subclinical or full clinical presentations of anxiety and depression that they need help with. And 74% of US mothers say that they feel mentally worse since the pandemic began. Again, that is a 2020 statistic, but again, I put it up there so that everybody understands and enters conversations and services with birthing individuals, knowing that most parenting individuals, most pregnant postpartum parenting individuals are having a lot of mental stress at this time. And we should be assessing that in every conversation. The long-term overall risk of suicide in pregnant and postpartum women is huge. It's 17 times the general population. That's on par with what first responders experience, who have event trauma every single day for their jobs. And so you're looking at a huge increase in the risk of suicide among this population, which is one of the reasons we say it is one of the most vulnerable times of an individual's life. And it is 70 times higher during the first year postpartum. So again, that's why efforts such as the fourth trimester Arizona and many of the other organizations that really support that postpartum period of the 12 months following the birth of a child are critical to our communities, because this is a time of low support and high stress, creating lots and lots of vulnerability. And if you have entered the pregnancy and the postpartum period with a history that's loaded by adverse childhood experiences, if you're experiencing adverse community environments, and then you have a birth trauma or an additional birth trauma, if you're in an unsafe relationship, et cetera, then your risk for suicide as well as substance abuse is sky high. So again, I want to make sure that we're understanding that this information is being studied in males as well as birthing people who identify as female and those who don't in the LGBTQ population. So 4 to 25%, that's a huge range. I always like to say the range is because it is a self-report statistic. And so we have to keep in mind that in some populations, people do not feel comfortable reporting mental health, that they're struggling. And in other populations, they feel more secure self-reporting that. But one thing that I have been hearing from my colleagues and certainly have been experiencing myself is that the statistic is likely much, much higher among fathers and mothers who are experiencing PMAD, stands for perinatal mood and anxiety disorders. So you're going to see that. So the comorbidity rate with maternal PMADs is very high. So if mom and partner are both suffering, the family is in trouble. And so what we want to know is if mom is suffering, the statistics from Postpartum Support International say that if mom, the birthing person, is struggling, the father or the partner is at 50% likelihood. So that risk jumps from 4 to 25 to up to 50. And most times they are going to suffer, especially if they don't have a very strong support system. And so again, you want to look at the trauma load. So we want to be looking at the biological risk factors, the ecological risk factors, the impacts on the family. We want to be thinking about how we can prevent as well as intervene. And a lot of that is educational programs for birthing people and their partners and families during pregnancy, or even as they are planning to become pregnant, as well as in the 4th trimester after birth. And, just again, looking at what are the comorbidities with maternal depression, making sure that we're assessing if mom's not doing well, or if the birthing person isn't doing well, how is partner doing? How's the family doing? So I wanted to provide, kind of a look at how to ask about risk factors, protective factors, and how to look at behavioral warning signs. And again, it really depends on how comfortable the birthing person and their partner or family may feel with us as service providers, as to how much they tell us about their history of trauma, their history of psychiatric or psychological mental illness, what their social stressors may be like. But I often try to say, if we're going to talk about what's risk in their life, let's also talk about what's resilience in their life. And so we don't want to talk all about trauma and leave people with the impression that they can't do anything about it, that they're a victim of their circumstances. We want them to know that there are lots and lots of ways to get treatment, to heal from trauma, and to increase their protective factors in life to give themselves and their children the best outcomes possible. So with individuals with a very low level of trust for the medical world and service providers, either coming into their home or coming into care, we want to be looking for behavioral warning signs such as irritable, agitated, depressed affect. Just how do they look? How are they interacting? Are there unexpected changes or big significant changes during the conversation? If they're fidgety, evasive, or hesitant, in sharing, then we want to take extra, caution and care with those individuals because their risk is going to be higher. So let's talk a little bit about some screening tools that we can use for individuals who are pregnant or who are postpartum, and this includes the birthing person as well as partner. There is a validated screening tool called the Edinburgh Postnatal Depression Scale, or the EPDS, that can be used. It is just 10 questions. And the questions are going to ask about depressive symptoms, sad symptoms, Anxious or nervous or worrying kinds of symptoms, sleep deprivation, it's going to assess how good and how good of a quality sleep they're getting. And I like to highlight item number 10 here, which is the thought of harming myself has occurred to me. So if an individual answers positively on item number 10, if they say hardly ever, sometimes, or yes, quite often, we always want to make sure that we talk about that. And I like to say, even if they say never, I always like to just ask, because in assessing that question, I often find that individuals will say, well, I didn't want to say because I was worried that you were going to take my baby away. So we have to keep in mind that individuals can be very worried about self-reporting honestly with these tools, and that there's a good reason for that. Our system has not always been trauma informed, and in many ways still isn't. And we're really battling that and that perception in the community. And so anything that we can do to, again, build that trusting rapport, to establish trauma-informed environments, and to let the person know that we're there to support them, and to help them increase their protective factors and lower their risk factors, the better we're able to actually get to the bottom of what their needs are and how we can help. So I do also want to say that the screening tool isn't everything. The score isn't everything. So screening without an accurate additional assessment can actually be more harmful than helpful. And so you want to make sure that you have a good, strong behavioral health person that you're collaborating with, someone who understands how to do that further assessment. The U.S. Prevention Task Force, as well, the U.S. Prevention Services Task Force, as well as the American College of Obstetrics and Gynecologists, the American Academy of Pediatricians, and the American Academy of Family Practitioners all recommend that the EPDS be used at least once during pregnancy and at least once during the postpartum period to assess for perinatal mood and anxiety disorders. But again, screening without assessment isn't enough. So we want to make sure that we have a really strong assessment. And what do we do next? If we have a positive screen, then what do we do? Set up, because a lot of times that's where, why are we even screening if we don't have a care pathway set up for an individual who needs help? Do we know for sure that we can get that person into care in a reasonable time frame? Do we know providers who accept their insurance? Do we know that the individual has access, transportation, or virtual access, if that's the type of care? So it's more than just screening, but this is a great evidence-based screening tool that can be used. There's also a new mom checklist for maternal mental health from Postpartum Progress and from Postpartum Support International, which is available. It is a checklist that new parents can use to take in with them to see a provider for the first time if they're concerned about their own mental health. And so that's a great resource. And the links, I will make sure that the links are part of the slides. So at this point, I'm going to turn it over to my colleague, Dr. Valerie Kading, who is going to speak from this point forward, and then we'll have some time for questions.
Thank you, Cara. Good morning, everybody. It's so exciting to hear more and more experts and professionals talking about ACEs and trauma. And I think without that knowledge, we will have difficulty in terms of really getting into the root cause of why individuals are suffering or using substances to cope with their feelings and thoughts, and other medical conditions that are really directly related to trauma. And so, the question is, if we understand that there's a dose response in terms of ACE score and risk for depression, anxiety, substance use, chronic medical issues, chronic pain, do we treat these people just like we would treat someone who doesn't have a history of severe childhood trauma or trauma in general? And the answer is really no. We really want to make sure that we're providing care that's trauma informed. And I've heard individuals talk about trauma-informed care, and this is something that happens in an organization. And I think that there's very varied perceptions and definitions of what trauma-informed care is and looks like. And it's, really just a pleasure for me to be able to speak to what trauma-informed looks like, and something that we all are striving for in order for us to really effectively take care of these women and moms that are coming to us for help, and they're using substances, or they're experiencing severe depression, because we all know that those experiences like substance use and depression, anxiety really affect the children at home and the family. So what's trauma-informed care? There's 3 core elements to it, which are called the 3 E's. So event, experience, effects. Event is the actual event that is either extreme or an actual threat of harm. So it could be physical, so rape. We'll see veterans who have been in combat experience trauma. They feel there's a threat to their life, or they've been physically assaulted. There's also psychological events that are traumatic, such as neglect, verbal abuse, emotional abuse, and I don't have to go in depth. We all know what that is. When someone is, again, very, very demeaning or neglectful, that can cause psychological abuse. And this event could be one event, or it could be repetitive over time. Experience. So that is actually how the individual experiences this event, and it's their perception. Was this traumatic or not? So essentially, I'm not going to judge Cara for what she thinks has been traumatic in her life. It is her perception of what's been traumatic. And everybody perceives that event very differently. Some people will say, oh my gosh, why me? This is so horrible, I'll never get over this. And some people will say, you know what, I had a sibling or a friend who had a much worse experience, and this wasn't so traumatic for me. So again, it's really dependent on the individual and how they experience it. And it's also influenced by cultural beliefs, how resilient that person is, and then where they are in their age. We would assume that a child who was experiencing a traumatic event at the age of 5 may perceive it very differently, the same event, if that person was 45 years old. So those are all factors that play into it. And really just, cultural beliefs. I always give this example of myself. I'm Filipino, very much so grew up in a very traditional Filipino household. And whenever I was being not so pleasant as a young girl, my mom would chase me around with a slipper. And that's what a lot of Filipino moms did. And I didn't necessarily think that was traumatic, because all these other little girls my age would have moms that did that. But if, let's say, another little girl my age from a different culture had the same experience, that could completely be another experience for that little girl. So that's experience. And then effects. So the effects of the trauma, that could be, the effects of the trauma could occur immediately, or it could be delayed. So for example, let's say a child or woman was sexually assaulted. She could go into, we say in the mental health world, freeze. So she, locks up and freezes, and that's the effect. And then let's say she kind of stuffs that away and never thinks about it. But then maybe 20 years down the road, there's something that triggers that trauma and that memory. And then she has some sort of delayed response at the age of 40 and has no idea why she's reacting a certain way, and doesn't necessarily link that traumatic event when she was younger to how she's experiencing it today. So again, effects that could be very, very different. with different individuals, and it could look like hypervigilance, it could look like avoiding or fleeing. It also clearly has physical effects. So we know that individuals who have certain autoimmune disorders like fibromyalgia or chronic back pain, those are all related to trauma conditions. So we want to make sure that we're considering all those factors when we're meeting moms who have certain medical, physical issues, and they may not necessarily be able to tie that back to some sort of trauma in their life. What's very important is that in terms of trauma-informed care, that we have to have certain assumptions. And that means that when you're in your workplace or in an environment, individuals across that organization really should have an understanding, a general understanding of what trauma is and how it affects that individual, the family, the community. It's not placing any sort of blame on the individual. And it's being able to make that connection between behaviors that are maybe not so attractive behaviors to trauma. So I know there's times where healthcare professionals become frustrated because of certain behaviors. And so being a trauma-informed provider would that person would be able to say, well, you know what, this behavior is not necessarily appropriate, but there's something behind this, and could it be trauma? So the assumptions would be realization. So you want to make sure that you recognize the signs of trauma. You want to be able to screen for trauma and assess for trauma. So as part of the assessment process, asking about adverse childhood experiences. So we talked about ACEs and looking at ACE score and knowing that 3 or 4 ACEs really, again, dose response to other health issues, and being able to recognize and train and learn about trauma. Recognizing, and that means that you're again understanding what trauma is and making sure the team is very, very educated on that. Responding. So responding to the patients, making sure that you have an environment that's supportive, having a mission where you're not just providing medical care, but that this care is trauma informed, and declaring that that's what you're going to do. And then resisting re-traumatizing events. And so this is really interesting because many organizations, we all have them, we have policies in place. We do things that are procedural in order to keep the environment safe, to keep patients safe. And then we realize, oh my gosh, was that really a trauma-informed care process? And so I just encourage you all to look at your practices and see if that is truly trauma-informed care and what you do about it. And again, this isn't, no one's perfect at this. We're all striving to be better, but awareness and understanding how we can inadvertently re-traumatize our patients, that is a huge first step into realizing how you can become better at trauma-informed care. And one example that I will share with this is, so at CR Tucson, we provide inpatient behavioral health, trauma care, and also chronic pain care. And we also have a residential component. So we have individuals that we treat for up to a month or more. And in order for us to keep our environment safe, every single person that comes to our facility, we do a skin check. The nurses will do a skin check. They get into a gown, and then the nurses will look at the skin and also make sure that there isn't any items that are brought onto our campus that could be unsafe. And so we do that to keep our folks safe. But then is that completely trauma-informed care? Because we have individuals who are coming for trauma, and maybe those that don't know they're coming in for trauma, but we're treating them, and they can get triggered. So, looking at various procedures and making adjustments so that it's more in line with addressing trauma. 6 fundamental principles for trauma-informed care is safety. So staff, clients, You want to create an environment where they feel physically and psychologically safe. Trustworthiness and transparency. So what you're doing in your organization or how you're providing care or interacting, you're making sure that it's transparent, that the mom is involved in the care, and that you're providing care and a relationship that is really based on trustworthiness. Peer support, it's always great to have individuals part of the care team who have experienced similar traumas, so that it's certainly something that is supportive, and they don't feel that there's additional judgment, and that there's someone in their treatment team that has the support as well, and the lived experience. And then collaboration and mutuality, and that's basically partnering with the client. So meeting them where they're at in their treatment, and not being the individual or treatment team that says, this is how we're going to do it and you have no choice. Empowerment, very similar to that, is making sure that the client, the staff are very important, and that their voices are heard. And then cultural, historical, and gender issues. And it's great to see many organizations doing this with DEI, addressing cultural stereotypes and biases, and then gender inequality. And so one of the things that we've done too is really move towards making sure that with our LGBTQI population, that we're treating them and meeting them where they're at in their treatment process, and then also making sure that our staff are very knowledgeable and informed with that population as well. So we're going to move into, and I know that was a lot in one slide. Well, I'll have my contact information at the end if anyone has any questions. And so, this slide in substance use in Arizona, it was great to see all the other very specific information on pregnancy and SUD in Arizona. And I really put this slide up and really in order to just show the significance of substance use in our state. And the left picture there shows the total emergency and inpatient visits involving suspected drug overdoses. And so you can see that it's over 12,000 individuals. And when I created this slide, it was a couple of weeks ago. And today's slide shows 880 more lives added to that number. And so this is not going away, it's getting worse. And the largest age group affected by the suspected drug overdose is the age group of 25 to 34. So we know this is the women that we treat and work with fall under this age group. And the highest concentration you can see there is in Maricopa and Pima County, where I would say significant of us reside. And so it's important to know that there's drug use here in Arizona is very, very significant. And from what we know from ACEs is that many of these women also have trauma, and they also have mood disorders. And so for us to, again, in terms of treatment, just look at substance use as the only diagnosis and just treating substance use, we're not going to get far in terms of treatment. We're not going to get to the root cause of why this woman is using substances. And we really need to, again, look at how we're treating women who are suffering from substance use disorders. The picture on the right shows the number of drugs that are involved in verified non-fatal overdoses. And so you can see here that the majority of the women, or the population, 39, almost 40% are by one drug, and it's most of it is opiates, and then a third are two drugs. So there's a significant number of individuals that are this isn't recreation. These are individuals who are using a combination of medications, and they're typically opiates. So fentanyl is the number one drug involved in overdose cases in Arizona. About 60% they're finding are using fentanyl. and the top 3 are opiates. So fentanyl, oxycodone, and other opiates. So that, as we know, could cause to death. And then especially if a mom is pregnant, that has some serious significant effects for the fetus and how the treatment is for that baby once the baby is born. And then also, how do we treat that mom when she's pregnant and using opiates? And so those are all the things that are very important to be able to address. And it's not just the medication part, it's again, the trauma, being able to address what is the root cause of all of this. All right, so I wanted to share a Sierra Tucson's model with all of you because this kind of ties in a lot of what I just spoke about and what Cara spoke about in terms of all of us wanting to be the best providers for moms and their families and being able to address the root cause of not just substance use, but again, mental health issues, because I have never seen an individual who just had a substance use disorder issue. There is always a second, a third, a fourth issue that we're treating. And in order for us to be truly a trauma informed and a very comprehensive provider, we really need to make sure that we're touching all of these things. We all have seen it where a mom gets help for one issue and then she gets referred for a second issue or third, and then it can become a very, very fragmented treatment plan for the mom, who at some point may or may not get frustrated and give up, and then she doesn't get the help that she needs. So again, this is, I'm just, very honored to work at Sierra Tucson and lead the team, and again, want to share with you what we do. And again, happy to collaborate with anybody in this conference. And I know I've had some conversations with many of you in the past. And again, just so passionate about making sure that we get moms and their families the help that they need. So Sierra Tucson is we have inpatient behavioral health, level of care, residential, and also outpatient program in Scottsdale, in Tucson, and in Texas. And so we have an integrated program where we not only look at the mental health, behavioral health issues, but we look at the body and also the spirit, because again, we're not treating just everything above the head, but we're looking at how does a mom and an individual's history of trauma affect what's going on today. And if y'all haven't read the book, The Body Keeps the Score, I encourage you to do that. Essentially, when an individual experiences trauma, they unknowingly have certain again, experiences, responses, and that the body is part of that. So I think one great example of that, and I'll just make this very, very simple, is if someone has had, let's say, sexual abuse in the past, and they believe that they have dealt with the trauma and that they are successful professionals and their life is fine, but yet something happens, and let's say they are, there's some sort of physical experience, maybe they had been touched a certain way, they'll get triggered by it and that trauma response comes up. In addition to that, again, I spoke about fibromyalgia and other autoimmune disorders. We've also seen from ACEs study that there's a higher risk for heart attack, high blood pressure, medical conditions. This is what it means where these trauma responses not just affect your thoughts and feelings, but there is literally a physical component to trauma, and certain biological responses that happen to trauma. And so I'm not going to get into all the details of it, but I encourage you all to read the book. It's very, very insightful and something that you can share with your clients when you're working with them. So this integrated program of really addressing not just the mind, the emotions, but also the body. We provide EMDR. Acupuncture, but we do offer EMDR, and that's also part of the trauma-focused and informed care. We want to make sure that we have a multidisciplinary team. I believe, and we all believe here, there is not one discipline that has the answers to helping an individual. We all come together. I always love it when I see a physician psychiatrist go to a naturopath and say, I've tried several medications, nothing's working. How can we help this individual by using certain naturopathic remedies or interventions? And it's a very collaborative process where, again, there's a lot of people involved in addressing the individuals that come here and the moms that get care here. Obviously, medical and psychiatric care is extremely important as well. There's certainly medications that can be used if a mom's pregnant and using opiates or other substances. And then also there's definitely times where antidepressants are necessary. And so making sure that that's also part of the treatment if needed. And then specialty programming. So making sure that a mom isn't just getting help for the issues at hand with being a mom or postpartum, but that, boy, if she's a licensed professional, if she's a nurse or a medical provider, that she's getting additional support with that in terms of, what does this mean for me as a professional and how does it impact my job? Or if she also has, let's say, a eating disorder or disordered eating pattern, how can we help her and support her through this really, really challenging time in her life? So making sure that we're meeting the individual where they're at in life and what's going on, and that we are all working together collaboratively, and then making sure that this environment for the mom and the patients are, again, very trauma focused and informed, and that creating physical and psychological safety is a huge priority for me, and making sure that it's not just the clients that come here that feel safe, but also the staff, because if they feel safe, then they're doing a much better job in terms of helping our clients here. So that's the last slide that I have for that. And, thank you all for attending, and we can open it up for questions.
We've been getting some questions in, so I can go over some of those for you, but I have to say thank you, because you and Cara both have been answering a lot of them as we go along. So I'm just going to suggest to our audience, if you're not following the chat, you might want to do it, because they've included many resources and links that I think you're going to enjoy. But let's go back to a couple of them, even if some of these, even if you did answer them in the chat, they might be interesting for the rest of our audience. We have, is there an inpatient treatment in Arizona where moms can bring their children with them?
Great question. We are unfortunately pretty sadly under-resourced in the state of Arizona. We know that in the United Kingdom, in Australia, and in France, they have what is called a mother and baby unit, which is an inclusive dyad care, kind of an organized care that wraps around the dyad, so that as mom is experiencing a psychiatric illness to where she needs help caring for herself, as well as caring for baby. She can get the care that she needs while she's also bonding with baby, increasing her own confidence in both, feeding baby and caring for baby while she is getting the help that she needs. So to go back to the question, do we have one in Arizona? The inpatient opportunities here are pretty slim. Dr. Kading, do you know of an inpatient facility where moms are able to have babies?
I do not. I know that's something that I have been exploring here at Sierra Tucson. So, but we do not at this time. What we've done at Sierra Tucson is definitely set up an environment where a mom can breastfeed and we can freeze the milk if she wants, or have baby come visit every day. But in terms of having the baby here on campus, we are not at that point yet, unfortunately, but something I am exploring.
I also know that in the United States, there are only about 3 inpatient perinatal specialty psychiatric units that provide, perinatal specific mental health care. And that, those tend to be mental health, not substance use. So not, both at once. They do tend to be more trauma informed and more specific to new parents. But there are only 3 in the United States. The University of North Carolina has one that I know of, and I've heard of one in Pennsylvania, I believe. But that doesn't help much when you have someone in Arizona who needs the care. And so certainly at the state level, there have been lots of conversations about what we can do to increase the amount of inpatient and fully supervised care. There are a lot of barriers to that because you're looking at a healthcare system that reimburses, from the insurance perspective for the mom, or, who is the patient. So are we getting reimbursement for treating the mom, or are we getting treatment for the baby? Well, it's both. So when it's both, we don't always have that insurance bundle, like we do during prenatal care, where the insurance company will reimburse the provider an X amount, for the entire prenatal care, and then an X amount for the postnatal care. So we need to work on that as a state and as a nation. Like I mentioned, there's only 3 nationally, and they're really only for moms. We don't have a mom and baby unit yet in the United States. So there are a lot of factors there that we need to address.
Thank you, Cara. I think this is a really good question, the next one we have. And I have to tell you, the reason I know Cara is because we both worked with Postpartum International to help set up the first Arizona chapter. And that was some years ago, but this one I know she will want to answer. And it's the question, because we're starting to do so much better about screening women, but when you get a positive screening, how do you access care, and how do you find a provider, and how do you develop a pathway to care for that individual?
That's a great question, and it's a really important question. Dr. Kading, do you want to take that one, or do you want me to?
Go ahead.
Okay, so I'll speak from my own experience and how I've done it. So first and foremost, we look at what are we currently doing, and then we look at, okay, where are the gaps starting? So for example, if we're not even screening every mom yet, then we look at how do we implement a screening system. And then we look at, okay, now that we've got maybe the screening tool that we need to get into our electronic health record. And then, who does the screening tool? Does the front office desk calculate the score, and then, make sure that the provider has that. So, it's that operational bit of who does it, and then who sees it. And then how do we talk about that as a medical team? Because you want to make sure that it's consistent across everybody on the team. You want to make sure that there's been a training so that people know what the tool is, where it's available in the electronic health system, how it's going to be used, how it's going to be scored, how it's going to be charted, and then what the conversation is going to be with the parent. And a lot of times people will say, well, what do I say? If a person, answered positively on item number 10, and they say they sometimes think about self-harm, what do I say? Do I call the police? And that is, of course, the thing that parents fear the most, is that they're going to have the police called on them because they answered honestly. So do we need to call the police? Probably not. We probably need to have that further conversation about, okay, so how, tell me a little bit more about, you mentioned that you sometimes think about self-harm. Tell me about that. I've had parents say anything from, oh, well, when I was 6 years old, I thought about drowning myself in the bathtub, but nothing since then. Okay, well, that's a long time ago, but anything recently, and they'll say sometimes, no, nothing recent. And I'll say, well, just to let you know, this is an open conversation because parents often experience stress. Parenting is hard. Being pregnant is hard. Being in a state where we can't have complete control over our bodies is hard and it's stressful. And sometimes it makes us think things like, oh, I'd just like to go to sleep and never wake up, or I'd like to just, drive my car into a tree. And these are intrusive thoughts that go right in alignment with stress. So if you're having any of those thoughts, first of all, the door is open. Let's talk about it. And second of all, know that it's very common and that it's an indicator of stress. And so again, you want to come in and let's talk about it. And let's, try to get you some additional help. We'll work on some coping skills. All of that can be done in the OB environment. It doesn't even require a behavioral health provider on staff, but if the person is really having a severe, suicidality is very present for them, they think about it all the time. There's the mobile crisis unit, the impact crisis unit here in the Phoenix area. Certainly I try to avoid getting, like a 911 call or that kind of thing. My recommendation would be, as a team, talk together about what your community resources are. And if you aren't sure what those community resources are, see if you can reach out to like a behavioral health organization in the community. Like here in Arizona, we have many, Southwest, Touchstone, some of those that I worked for previously in my career, who might be able to connect you to some additional resources and, kind of give you some ideas for individuals depending on their insurance type, so that you know where to send them. The other thing I really recommend is getting in touch. So there are a lot of private practitioners who accept insurance across Arizona who also offer virtual therapy. And so these are individuals who, here in Arizona, I've treated people from Flagstaff, I've, treated people from Navajo Nation. So, there's a lot more providers who are offering virtual care now. So if you're in a rural area and you're pretty resource poor when it comes to mental health providers, see if you can establish a relationship by reaching out to Postpartum Support International's Arizona chapter, because they know who in the state of Arizona has completed the 2-day training, and they may be able to connect you with somebody who would be willing to do virtual consultations with you and your team, as well as the individuals that you're treating who might need care, if there's no one in your area who's able to give that care. So there's a lot of different ways to do it. The biggest and most important thing is to look at your own team and look what you're already doing, and then really be honest about what you're not doing and what you can possibly do. Because this is, adding something to everybody's job description is change. That's hard for the team. From an operational perspective, you need to make sure that the team is prepared to do it. Don't just tell them we're going to start screening and, we're going to make this happen, because that can actually be more harmful for both the patient and your team. So think about it, make a good plan, and please email me if you have any questions and you want, some consultation around how to do that well.
Thanks, Cara. I think that's so important. Valerie, can I ask you a quick question?
Sure.
I really liked your slide where you were talking about when you have somebody that you're treating, that it's never just one thing, that there's always, whether it's substance abuse and, or where there's a perinatal mood disorder, there might also be substance abuse, or the other way around. It seems to me sometimes there's the chicken and the egg thing. And I wanted to see what your thoughts were on that, where we don't really know sometimes if a woman was experiencing perinatal mood disorders and succumb to all the self-talk that we do about, oh, it's nothing, I'll be okay. And then finally ends up kind of self-medicating those symptoms by trying substance use. Or if it's the other way around, they're by being a substance user, she puts herself at higher risk for perinatal mood disorders.
It's all interconnected, and I don't think we have an answer which one is the chicken and which one is the egg. And so I think the one thing that I always remind everybody is I just don't think we're doing a good enough job with really asking those questions, like, what was your childhood like? And I will bet you that you'll be the first person that has asked that question, or many, many times, because it just doesn't ever get asked. And that there's also the experience part of the situation is maybe the person doesn't even think that experience was a traumatic one, but we're able to identify that. But I would say that generally most of the individuals that we treat have had some sort of trauma in the past. And but I wouldn't go far as say that was that's the entire story. It's a huge part of it, but there's also the genetic component to every individual. It's, again, the experience, but really it's just highlighting the importance of making sure that we're all not just looking at what's going on today, but asking what's happened in the past. And when someone is coming in for substance use treatment, that we're exploring and we're really looking at what other factors, what's their life story, what else can we treat? Because if we don't get to the root cause of, again, why that individual's been using, we're not going to get far in treatment.
Thank you so much. I want to thank both of you for an absolutely wonderful presentation. And you were so responsive to the questions that did come in on chat by answering them there. So you've streamlined our conference, and I appreciate that as the moderator. Thank you so much. We're going to move into our next piece of the agenda for today. And I think we've had a wonderful morning, but now we're going to do a short lunch break. But it's going to be a special lunch break. We want you to take some time and grab something to eat, but please come back at 12:45, because at that time, we're going to be previewing a new 10-minute video created as part of the ADHS Stigma Reduction Campaign, Substance Use and Women. The video captures the stories of 7 unique women who were willing to share their story about their substance use disorder and their journey to hope and healing. This video contains information and experiences that are sensitive in nature and may be emotionally triggering. The experiences shared are for learning purposes only. You may choose to turn off your camera, step away, or grab a drink of water. But again, we want to continue to encourage you to take care of yourself. So please take a break, and then we'll meet you back here at 12:45. And believe me, you're not going to want to miss this 10-minute video. It's very wonderful. Thank you.
My name is Jessica. I'm 42 years old, and today I consider myself a free, loving mother. I have one son I just recently had 4 months ago, and I think that my son is like a super kid. And so, I mean, I guess all moms feel like that, but I really feel like my son is, just because, like, I think he could say I love you already. Like, every time I walk in the room, he like lights up, and there's nothing like being loved by somebody and he sees no flaws. He knows no flaws, and I'm just, in his eyes, perfect, although I'm far from that. My trauma started, honestly, when I was 7 years old. My dad died. He was murdered. With taking such a loss at such a young age, it traumatized not just me, but my entire family. With losing my dad, my mom ended up, which she's always been a great mom as she is today, but she ended up getting strung out on drugs and a heroin addict, and my family just fell apart.
I actually didn't have a mother or a father growing up. My mom's been on heroin since I was young, and I never got the chance to meet my father.
It all started with the trauma that I had when I was 3 or 4 years old. My uncle had molested me, and then when I got to be about 15, 14, he injected me with heroin. And he had me sell my body so that I would provide for his habit and my own.
I didn't know myself. I didn't like what I did know of myself, and I didn't want to find out anymore because I knew that whatever it was that I knew, I hated.
I do have abuse in my background. I could pedal around and just kind of like go through all of my life experiences, but just to sum it up, I've been through a lot of shit.
What started my addiction, I had like a lot of trauma, and so I guess I didn't want to think about the past. I didn't want to think about the present or the future, and so that's why I turned to drugs, and drugs is what did it, and it was a downfall from there. It was just not, I don't know how to, addiction's just not good. It's scary. It's really scary.
Honestly, the first time I did heroin, it was like, this is it. Like, I genuinely thought to myself, like, this is what I'm gonna do for the rest of my life. And I was A-okay with that.
Falling into opioid use was not something that I had planned. It's not something that I kind of even knew what I was doing. I just started taking pills one day and ended up getting something that wasn't as easy as I thought to stop doing.
People on drugs don't want to stay on drugs. Nobody's just happy and content with their life like that. But there's got to be a reason for you to get sober. And so when you find that reason, then you go and you seek the treatment.
At first, I didn't really I didn't care if I lived or not, honestly. I didn't feel like I had a purpose in life. I was just like, I'm just wasting oxygen, I guess. But then I got pregnant, and it was just a big blessing. Turned my life around.
I don't think it's until I got pregnant that I genuinely wanted to get clean and thought it was possible.
I was pregnant since April of last year. I found out in July. I looked at it as a blessing. That was the reason, to stay sober and to continue with my treatment. Everything happens for a reason, and I looked at that as something that was meant to happen to continue to push me to be the strong woman and person that I am.
Well, this last time I went to jail, I found out I was pregnant. And I couldn't believe it. I went back out on the streets and I was like trying to figure out what am I gonna do. And so I went to this program, CMS, and I found out that they had another program called Hushabye. They're like a lifesaver because they taught me everything. Everything you can think of learning for a baby that was substance exposed.
I wanted to be able to speak with people that would understand where I was coming from. Because in that situation, you kind of feel like you're the bad guy. Like, I'm the one that messed up. These people are just gonna look at me like I'm some drug addict. And like, I just wanted to walk into a facility or a place and people would treat me like they would treat anybody else, and that's how I felt at Hushabye.
The one thing that women are scared of to like reach out is like being judged and like people looking at us wrong, but Hushabye, there's no judgment at all. They're amazing women.
My name's Clarissa Collins, and I'm a peer support specialist with Hushabye Nursery. Our main goal is to help moms that are struggling with substance use disorder get into medication-assisted treatment while they're pregnant so that they can parent happy, healthy when baby gets home. My story with opiate use disorder began right after I had my daughter when I was 18, and I was just not ready. So now that I'm healthy and in a very stable place of recovery, I'm able to help other moms that are struggling walk the same path to get to the same point in life that I am. Sometimes all it takes is, you've got this. You're a good mom and you've got this. And I've seen those few words change a mom's entire perspective on things. That's the magic right there, is getting them to believe in themselves and them to understand that I can do this and I'm not a bad mom if I struggle.
When I was pregnant and I went into labor and I was in the hospital, the nurses there I felt like were super judgmental because I was honest that I was, on methadone and that my baby was going to be more substance exposed and stuff. And I had a lot of education about it, but the nurses don't. There's just pure judgment, like, oh, this, lady's on drugs, her baby's, like if I didn't care about my son, but they didn't realize I went through so much program to learn how to be a better mother before he was even here. And so I feel like that's one of the biggest experiences I had with being judged, is that they didn't know that I knew how to take care of my son or myself.
Just know me as someone who overcame everything, overcame things I wasn't even supposed to. And look at where the heck I am. I'm speaking to a world that I don't even know who's gonna be hearing me. I don't even know, but I hope my kids see it one day. That's all I care about. I don't care about what the world thinks about me. I just want them to see me and be proud.
I view my future now as being the best I can for my daughter, the best mom and the hard worker for hers, because I want her to look up to me and be like, I want to be like my mom one day. And I just want to give her everything I never had. I just want to give her happiness and love.
My past doesn't define me at all. I learned from it, and that's helped build my character, but it doesn't define who I am. I'm not that hooker. I'm not that stripper. I'm not that drug dealer. I'm a good person. I love helping people. That's my purpose in life. I used to say my syringe was half full. Now I say my cup is half full because I drink coffee now. See me differently. See me for who I am and not who I was. Because who I am now is someone who I'm really proud of.
It might sound crazy or funny or whatever, but I really feel like my purpose today is to help somebody else, to know that, there is a light at the end of the tunnel. And for so many years, it looked like there wasn't. And there is, and there will be somebody right there to reach out and give you their hand. And I'm one of those people, and so I'm going to help whoever I can and save whoever I can and educate whoever I can.
Thank you so much, everyone, for joining us for that video. I just wanted to acknowledge all of the comments that are coming in the chat and all of the impactful statements, and it absolutely is an impactful video. I want to take a moment also to acknowledge the women highlighted in this video and their stories. Every mom who has suffered through substance use disorder has their own truth, and that truth is unique to each one of them. So let's see them differently as good mothers who are making progress to improve their lives and the lives of their children. Their stories can help others who may be going through the same thing, as well as connect women to the support and resources they need so that they can be successful parents. The video will be available in the fall on the ADHS website. Hope Heals website where it can be downloaded and shared. So thank you all very much, and I will pass it back over to Jeanette Shea, who will introduce our after lunch speaker. Thank you so much.
Thank you, Laura.